Hello to all. Thanks for joining us. We're just going to give a minute for folks to get in from the waiting room. Okay, I'm going to go ahead and get started. Welcome to today's webinar, which is called Purchasing Power Under Pressure, Employers and Unions Perspectives on Rising Healthcare Prices and the Role of Middlemen. We're really glad to have you joining us here today. I'm Laura Tolan. I'm a senior editor with Health Affairs, and I manage our Forefront series called Provider Prices in the Commercial Sector, which this webinar is a part of that series. For both the series and the webinar today, I want to thank Arnold Ventures for their support. So many of you will have seen that KFF released its annual health benefits survey a couple weeks ago, and the news continues to not be wonderful for employers. In 2025, the average annual premium for family health coverage hit nearly $27,000, which was a 6% increase over the previous year. And this is admittedly not as bad as it's been in several of the last 25 years, but it's still a growth rate on costs that far exceeds the rate of inflation. So what is an employer to do? We are going to get into some of that today with a particular focus on the newish and developing ecosystem of third-party vendors that have sprung up that are trying to mediate the relationship between the employers and unions as purchasers and providers. And we're going to talk about how these relationships can contribute to rising costs and what purchasers are thinking about them. Before we get started, a couple of housekeeping notes. The session is being recorded today, and both the video and the slides will be available on our site, healthaffairs.org, under the Events tab shortly after the event is over. We're going to start with presentations from each of our three speakers, who I will introduce in a minute. That will take about 30 minutes. And then after that, we'll go into a panel discussion amongst them. And I'll have some questions to ask them, but I'm also going to encourage you to submit your questions for any and all of them. Your questions can be submitted through the Q&A feature at the bottom of your screen. You don't need to wait until the discussion to type in your questions. Enter them at any time. Please keep them coming. And then when we get to the discussion, I'll be sifting through those and asking those questions of our panelists. So with that, I'm going to introduce our three panelists, and then I'll turn it over to the first one. So we're going to hear first from Andrea Caballero, who is Executive Director for Catalyst for Payment Reform. She's going to tell you what that is about. Next, we'll hear from Patrick Pine, who has recently retired as the Chief Administrative Officer of the Robert F. Kennedy Medical Plan, which is a Taft-Hartley trust serving farm workers and their families, primarily in California. And then next, we're going to hear from Katie Gudikson, who is Executive Editor of The Source on Healthcare Price and Competition, a newsletter I would highly recommend to you all with your interest in these issues. And that is at the UC Law in San Francisco. So with that, I'm going to turn it over to Andrea first. And again, I want to remind you, please feel free to put those questions in the chat at any time.
Thank you, Laura. And it's wonderful to be here with all of you. I'm going to start off this presentation with orienting you to who CPR is and also who our members work with, the middlemen and the many intermediaries that interact with employer purchasers. So just a little bit about CPR. We are a national nonprofit organization that works with large self-funded employers, public purchasers, and also Taft-Hartley trusts and benefits consultants to implement strategies, identify ways that employers can reduce their costs, improve quality, and really make the marketplace function better for themselves and their employees and members. We do this in a couple of ways. On one side of the screen here, you'll see that our members provide peer-to-peer learning. They learn from each other. Public learns from private, private learns from public, and they share strategies, and also they share their challenges, which in today's discussion, a lot of it is around the challenges. On the other side, we perform a lot of education, not only for employer purchasers, but policymakers, and we perform research to help lower costs and improve quality. So on this slide here, I don't expect anyone to see the words. That's not really the point of this. This is a flow chart that I worked on with Katie, who you'll hear from later, on a project that we and research we did on cross-market mergers. And in this exercise, we were trying to untangle the different roles that intermediaries play in a merger process. But at the center of it, you can see that they're self-funded employer purchasers, or they're also called plan sponsors. And the lines and the services and the funding flows in many different directions between, in this case, we see at least 4 different intermediaries. I took some inspiration from that first flowchart for another research project I did on out-of-network claims. And this is actually a pain point on the pricing side and on the fee side for employers, out-of-network claims payment. But as I was researching how are these fees paid and who are they paid to, I found myself having to map this out again and figure out who are these intermediaries and what are they doing, and how do employers know about them. So in this slide, some of the players are different, but again, at the center of this, you have self-funded employer purchasers, or the plan sponsor. Then recently you might have seen some research from our colleagues at Georgetown, and they published a report on the complex web of healthcare financial interests. And this looks pretty straightforward. This is a simplified model, and sort of the pink circle there, you see employer or union or the individual customer if it's a fully insured. And then they go through their insurance company and then have access to providers. The self-funded or self-insured illustration is at the bottom and looks very similar, except that it's just the employer and it's self-funded. This is, I think, how most people think employers interact with their TPA, or how they access provider services. But in reality, it looks more like this. And this is also from the Georgetown research. And this is extremely complex. And if you think about being an employer, who here again is in sort of the pink circles, and all of those different lines that flow from them, to them, through other organizations that they might not even know about, or what their contractual relationships are, it makes it incredibly hard for an employer to figure out how the system is working and whether or not it's working in their interest, and if they can even control costs and improve quality. So as I was going through all of these different flowcharts, it just made me think of a board game, or many board games. And if only it was as simple as a board game where you have transparent rules, everybody knows, who's winning here or who might be losing here. But in the relationships that we're going to talk about, it's not as those rules aren't always written in a way that everyone understands. So just to walk through a couple of the intermediaries that employer purchasers work with and why they need them. I have 2 slides here, so I'll go over them, but then we'll talk a little bit about how they may support employer purchasers, but how they also may have misaligned interests. So the first is a third-party administrator, this referred to as a TPA, and TPAs provide multiple services for a self-funded employer. And they are not assuming the financial risk for any claims. So they are not an insurer here. That's where the employer steps in, but they administer the benefits. They adjudicate the claims, they issue ID cards, they typically provide the network of providers that the employer is using. So that's a third-party administrator. On the benefits consultant side, those are organizations, typically large, sophisticated organizations that will advise employers in their procurement process. So They help employers with their RFP and who they should select maybe as their TPA or other vendors they might want to consider. They help an employer design their benefits and give them cost control strategies. So that's the role of a benefits consultant. And that can be at the beginning of a process, but it's usually a relationship that is maintained throughout a contract. Then you have what people will refer to as point solution vendors. These are organizations that many of you might know in terms of the behavioral health space or diabetes space, weight management, but they are sort of what I refer to as kind of a slice vendor that is performing a service for an employer that either the TPA can't provide or isn't, either willing to design for the employer, but they are providing a service that is not performed by the third-party administrator, but they do interact with the TPAs typically through business agreements. The last three I'll go over are pretty quickly. A repricer. This is an organization that essentially helps a TPA sometimes negotiate or reprices claims. I learned more about repricers when I was researching the out-of-network fees that employers pay, and that is a common function repricers perform. They will look at out-of-network claims and in some cases negotiate a different amount rather than the billed charge. So that's a repricer. Repricers also oftentimes have what's called a RAP or a gap network. That's sometimes how they can negotiate a lower out-of-network because it's a RAP network other than the TPA's network that it's providing the employer. And so this RAP network isn't something an employer typically engages with directly, but it is part of the relationships that all kind of go back to the TPA that the employer is working with. And then finally, a direct relationship that an employer typically has is with a stop-loss insurer. And we won't really be talking too much about stop-loss here, but it is another organization that the employer is paying fees to, and it's this organization is intended to help protect the self-funded employer from catastrophic claims, and they are usually in place at a certain dollar threshold. So the employer who is self-funding the claims is protected from those catastrophic claims. So I'm going to just go back to this slide and the third-party administrator, and because all sort of roads, with the exception of maybe the point solution vendor in some cases, lead back to the TPA. And with all of these intermediaries, even if every single contract was transparent and an employer could see everything, it's almost nearly impossible for the employer to understand how these relationships are interacting with each other and whether or not the employer is getting a good deal. TPAs are typically part of, they are insurers themselves. And so they either have their own insurance network that they are using on their fully insured side, or they're renting a network from a large insurer. And so these provider contract relationships they have are between the TPA or the insurer and the provider. They are not with the employer, and yet the employer is bound to the terms of that agreement, which in some cases can lead to higher fees. Benefits consultants too, they have other sides of their business that they're managing portfolios for. So whether it's a retirement business or other parts of their, maybe it's investment portfolio they're working on, which could be with other parts of the healthcare sector, let's say large health systems. And so sometimes their incentives are not aligned with the employer, the self-funded employer. And I'll just say that even though these relationships are incredibly hard for employers to navigate, it's also very difficult for them to extract themselves or switch from one TPA to another TPA. It can cause tremendous disruption to their employee population, which they really don't want to do. But if they need to, and if they think the fees and the services that they're paying for are better aligned, then they will. But it makes it very difficult to change these relationships. So that's kind of laying the groundwork of who employer purchasers work with and how sometimes their relationships are not aligned and their financial interests are not aligned with the employers and saving costs and improving quality. But with that, I'll turn it back to Laura, because then we're going to hear some real life experience with interacting with each of these players. Thank you.
Thank you, Andrea. And again, audience, send us those questions as they occur to you. Next, we're going to turn to Patrick Pine, as I said, who's recently retired from running the health plan for the farm workers, primarily in California. You're getting a heavily California slanted panel today. And I'll just turn it over to you, Patrick. Go ahead.
Thank you, Laura. Well, I want to thank Andrea. Just before I start all my remarks, that slide she showed with 4 board games. We have some employers we deal with union plans serve multiple employers. Some employers have more than one union contract. They might have them with 2 or 3 different unions, and then they have a non-union workforce. So if some of you work in HR for a larger company that's like that, you may feel like you're paying all 4 of those board games she displayed at the same time. So that's another complexity on top of everything else is I can talk about our particular plan and how it works, but some of the employers we serve, they are also working with 3 other distinct benefit plans. And that's something that a lot of people don't understand about some of the challenges in today's environment. So next slide, please. So this slide just gives you a little background of our plan. This is a somewhat unusual Taft-Hartley plan in a couple of respects. It's actually a rather, in the world of Taft-Hartley plans, it's on the smaller size end of Taft-Hartley plans. It's not tiny, but I would say it's smaller than some plans for, let's say, a Teamsters or some of the trade union can be 100 times larger than us. So some of you are probably dealing with large plans covering many more lives than we do. But even though we're small, we are a little bit different than many union plans in that we have a lot of what I would call smaller groups who are spread out through different parts of California and in other states. So we have a lot of small groups in different areas with different kinds of markets, conditions, different situations. A lot of the bigger plans will be largely in one region. They're not spread out kind of like we are. Another thing that we're a little different, we offer more options than a lot of plans do to members. And there's a historical reason I won't go into that. The other thing that we are a little unusual is we do use, for a rather small plan, more than one network arrangement. We do have one typical PPO rented network arrangement with Anthem Blue Cross for a segment of our population, and I won't go into the reasons why that happened. But we also have a network with Valence Health, which covers mostly non-hospital providers. We do have some hospitals that we have contracted, especially in areas where there's a limited availability of hospitals. And then for non-contracted hospitals, which is most of them, we use reference-based pricing. We also have been using Express Scripts as our PBM for many years, but every 3 years we've gone out to look at our process. And this year, for the first time in many years, we are in the process of switching to a new PBM, and that's a significant undertaking that we're in the middle of. So I just wanted to mention a little background on the plan. So some of my comments are perspective of the plan, but I also will try to give you an idea that some of the things we do are typical of any plan, no matter any union type plan, no matter how big. Next slide, please. So very quickly, we have several different relationships with third parties. We do use a major national consulting group, but it's on a fee-based contract basis. We have long said we will not do any commission-based arrangements. And there are some that ask to do commission. We have always said we don't want to do that because I think that increases the possibility of conflicts of interest. Secondly, we use a typical ASO agreement, however, for one segment of our population with Anthem. For the custom network, we also needed to have somebody provide a lot of the services that TPAs do. But then we hired another firm to do pre-authorizations, pre-certifications, and a firm that does some of the other TPA services is also providing a reference-based pricing arrangements. So we have a lot of different arrangements, and as Andrea touched on, those all can inherently have some conflicts. I do want to be clear that many of the people we work with at Anthem or some major national, we have great relationships. They serve us with integrity. I do believe they have our best interests, but they're these big insurance firms and some of these big firms, those policies that can create conflicts are set at the upper end of these companies. And so the people we deal with on an individual basis may have little control over dealing with what I call the inherent conflicts that can arise. Finally, I just want to mention there are some other arrangements that I haven't even listed here, but this gives you some idea of all the complexity that Andrea talked about before. And as I mentioned earlier on the first slide, we have many employers we serve where they have 4 or 5 different plans at the same time, and we're just one of those. So they face some difficulty and some confusion when their employees are saying, well, why don't I have that benefit? Well, you're not a member of that union and you're not in that plan. Next slide, please. So I just make several observations on this slide about our third-party relationships. Generally, what I have seen over the years is some of the firms we deal with, there have been changes in their ownership. Sometimes they change their branding, all legitimate reasons, but that can create challenges for us. We may have to change ID cards, or we have to explain that it's the same organization, but now it's under a different name. That creates problems. In our case, the fact that a majority of the population prefers speaking Spanish means that we prefer to have vendors who have some Spanish speaking availability on their staff. We generally get a lot of firms say, well, we use an interpretation service. We have found that does not work well for our population. We also look at situations like if we're using a major firm, are they going to be responsive to us as a smaller plan? Or are they going to, maybe we're going to get lost as a small fish in a big pond? So sometimes big is better, but from my perspective, it's not always better. The other thing that I would say is we have found a few vendors who grew very rapidly, and some have been able to still offer great cost-effective service to us. We have seen others that got big and we felt like they lost some of the delivery of services to us as effectively as it was the case when maybe that group was independent. So those are just some of the things that we look for, and I think other administrators are looking at the same thing. Next slide, please. So this slide just says, we have learned that there are always potential conflicting interests with many vendors, and what we do is we do express to those vendors and their representatives what those concerns are and some of our policies that are intended to minimize the impact on the plan and its members. Next slide, please. So very quickly, how does bargaining work and why does it cost so big a deal? Union representatives, when they meet with their members and say, what do you want me to bargain for? Almost invariably, they want more wages. Second to that, they want a good health plan at a low cost. And third, they might want retirement benefits or other benefits. On the other side of the table, the employer generally has an idea of how much money in total they're willing to commit. So when they're at the bargaining table, they'll tell the union rep, we've got one bucket of funds. You decide how much you want to go to wages versus benefits, health, or retirement. What happens is some employers also insist on contracts that cap the annual increase for health benefits and say if it goes over that amount, we can move that cost over to the employee, which the union side generally hates. So what has been going on is health prices rise faster than other categories. There's an increased pressure on unions to reduce wage demands in order to keep health benefits. And that's what many unions are objecting to. Next slide, please. So in our case, when I first saw the biggest demand and pressures to deal with costs was in 2014. After the ACA was adopted, they eliminated the plan's abilities to have what were known as annual limits. Some of you may remember that. In our case, we had a $70,000 annual limit, which was actually relatively generous at the time. We had to eliminate that, and that meant we had to, for the first time in history, buy stop loss insurance, which at the initial point was over $3 million on top of what was then a $20 million budget. That's a pretty big shock. We found some ways to mitigate the self insurance costs, but it still was a big kick at the time. And we started saying, what else can we do to control costs? Next slide, please. So the other factor we have is a lot of our members live in probably the most expensive hospital market in California and in the whole country. A lot of our members live in an area where 4 of the 7 highest priced hospitals are located. And as a result, we get a lot of utilization of the relatively expensive hospitals. That is the primary reason we moved to reference-based pricing, was to mitigate the problems we had dealing with a relatively expensive market. We also have adopted bill review more recently because we're finding on hospital inpatient charges, it's very common to see different forms of what some people call upcoding. On this slide, I would just say there's one example that we see all the time, and that's called unbundling items that should be in a bundled price. And I just very quickly, the analogy I say is, imagine going to a fast food place to buy a hamburger that's listed at $6. But instead, you get a bill later on from the fast food place that says, well, that was $6 for the burger, but by the way, here's a charge for the cheese and the patty. And all of a sudden, there's an $11 price on that burger, even though you were told it'd be $6. So I wanted to point those out. Let me go to the next slide, please. So we've done a number of things to mitigate healthcare costs, and we're very proud of what all the things are, and I'll deal with those in the Q&A. But if you can go to the next slide. That slide will illustrate all the things we've done to mitigate prices. By far, reference-based pricing and bill review have been done the most for us in controlling costs. And next slide, please. So the reason we feel like that's been effective is, as you can see on this chart, our costs per participant are less than half the national average, and our annual contribution increases the last few years have been below 4% every year. Even one year we had 0. We're very proud of that, but that's taken a lot of work, especially using some of the techniques we've employed to control costs. I'm going to stop at this point, and we'll address the other issues during Q&A.
Okay, yes, thank you, Patrick. We'll definitely circle back to hear more details about the things that have worked well for you. And there's been a question that popped up in the Q&A already wanting more details about the reference-based pricing. So for sure, we'll come back to that. But for now, let's move on. And I'd like to give the floor to Katie.
Thank you. I've been given the task of following up those great presentations by both Andrea and Patrick with trying to present some policy options, at least provide some hope or sort of talk about what could be done to help in this space. Next slide. So maybe the first thing to point out is I hope it's clear by now that employers can't do it alone. The data is still hard to obtain and interpret. There's kind of this opaque system of middleman that Andrea presented. We talked about financial incentives that create conflicts of interest. And as Andrea said, employers can be reluctant to change TPAs insurers frequently because they don't want to disrupt their employees. I think in the interest of time, I'll move to the next slide and present what I see as sort of a menu of options for policymakers, both at the state and federal level, to improve accountability, improve some of these pricing issues. And I'll talk just briefly about what's been done recently and what could be done in each of these spaces. And they're improved transparency, regulation of business practices or fiduciary duty, restrictions on specific contract provisions, increased antitrust oversight, and I'll wind up with some price restrictions, some discussion of that. So next slide. I think we all know that transparency is sort of fundamental to shining some light in this process. And there's two relatively recent price transparency rules, the hospital price transparency HPT and TIC transparency and coverage. If you want more details about how this is working and kind of a lot of the gaps and the way employers still struggle to use this information because it is so large, I would highly recommend people check out the PBGH reports that came out recently, where they are starting to use these for the largest employers. In addition, the Consolidated Appropriations Act of 2021 require brokers, consultants, and other service providers to disclose conflicts of interest in all financial compensation. And TPAs must disclose contract terms that would affect the fiduciary responsibility of the employer. I think there's a lot more opportunities here, including requiring TPAs to share complete claims, payment, denial, fee information. Sometimes fees can be baked into claims, and it can be really hard for employers to pull that out. And perhaps the best way to do this is to give employers full ownership of all the claims data. So they would have all pricing, rebates, fees, basically declare that the employer owns the data. Next slide, please. So the next sort of bucket of options that policymakers have would be to regulate fiduciary duty or even business practices. So as I said before, brokers and TPAs must now disclose their direct and indirect compensation. I would highlight an Indiana law that was passed earlier this year that now requires TPAs and PBMs to be fiduciaries to the employer. They have to act with loyalty and care. They must disclose fees. They have to avoid conflicts of interest and maintain transparency in financial and contractual obligations. This law is particularly helpful because it really spells out what that fiduciary duty means. In terms of future opportunities, I think doing something similar at the federal level, so to make TPAs and PBMs fiduciaries, could go a long way here, and in particular, standardize the definition of what it means to be a fiduciary would be important. Because ERISA already says that anyone with discretionary control is a fiduciary, it's important to point out what things constitute that discretionary control that would help elucidate some of this fiduciary responsibility. In addition, states or the federal government could prohibit spread pricing and specific types of compensation, sort of some of the ones that Patrick alluded to, business practices that give a TPA or a broker an incentive to have a higher price where they can say they have get a bigger discount. California passed a law this year that's specific to PBMs that does a lot of this work as well, but it does not apply to TPAs, just PBMs. Next slide, please. Similarly, some states now regulate specific contract provisions between insurers and providers. Nevada, Connecticut, Texas, Massachusetts, and Indiana all ban some kind of anti-tiering, anti-steering, or all or nothing clauses. Some of these states do both, and some just do one of those. Indiana now also bans make-whole provisions that shift financial consequences of any new regulations onto the plan. So if the hospital was now making less money, they would try to make that up with the plan, and that's now no longer legal in Indiana. Again, the future opportunities are sort of a federal type ban. It was in early versions of the Lower Healthcare Costs Act of 2019. So Congress has considered this, and it got quite far along, but then was removed when that bill was finally passed. And another place where regulation of specific contract provisions might be helpful is in a number of business practices that were highlighted in that Georgetown Cheer report that Andrea put up. Insurers can sometimes play off benefit the fully insured plans versus self-funded plans. And I can talk, in the interest of time, I'm not going to talk specifically about cross-plan offsets. That's talked about in the Cheer report, or we can talk about that in the Q&A. But I think I'll move to the next one. Next slide, please. Which is sort of the fourth bucket of opportunities for government and regulators to help out and back up employers. And that's to increase antitrust oversight and enforcement. I'm sure many of you are aware that many states now have their own merger review programs. So any providers or insurers often have to give notice in these states, or give notice in these states before a merger happens. And that allows states to review it, to see if it's in the best interest, what the anti-competitive concerns might be before the merger happens. And there were some recent changes about 1.5 years ago to the Hart-Scott-Rodino rule, which is a federal reporting rule that requires large transactions to report to the FTC and DOJ and have a waiting period before those transactions are consummated. And those there's additional ownership disclosures, and there's additional disclosures basically that require a lot more information about who owns the different plans. And in particular, what's important there is that it requires a lot more vertical relationships. So Andrea mentioned that a lot of these TPAs are now part of insurance, a much broader organization that includes insurers, et cetera. Well, many of these claims processes, all kinds of the things Andrea talked about, are now often fully integrated into these large systems. And there's all kinds of difficulties and lack of transparency in these vertically integrated organizations. And so a real review of sort of vertical mergers within the sort of payment or insurance TPA middlemen would be really important, and I think is not a part currently of most state review programs. So that would be one major recommendation I would make, would be to increase the scrutiny, require any of these entities that are consolidating to be reviewed by the state, and then recognizing that antitrust, there's been a lot of these markets are already very highly consolidated, to have increased attention by antitrust enforcers on the conduct of health systems. So any behavior that disadvantages their rivals or disadvantages customers could be used, but in an antitrust case. Next slide. And I'll talk just really briefly about price restrictions, because I know it's often the third rail here of policy interventions. But I would say many states are starting to dip their toes in here, recognizing that the market power of sort of all of these entities is really disadvantaging the public and driving up costs. 8 states now have cost growth benchmarks. Indiana and Vermont now have price cap legislation they just passed this year. And Oregon and Washington now set prices for their state employees that are set as a percentage of Medicare. I think the future opportunities are to explore this more and to target price caps to a subset of services, at least initially. So it could be out-of-network services. We can talk about the No Surprises Act in the comments about whether that's working very well or not. But states can also limit it to their own employees or to hospitals, et cetera. And last slide. And just to conclude, because I'm looking forward to the discussion, employers face a highly opaque system with multiple intermediaries whose financial incentives may not match theirs. Transparency rules have helped, but it's still really hard to be an employer out there. Some states have had success with TPA, PBM fiduciary duty laws and banning specific contract terms. But increased antitrust enforcement is still really critical and important, both at merger review and for behavior. And I'd encourage us to talk about additional policy actions at both the state and federal level. So yeah, I'll turn it back to Laura, and I'm looking forward to the discussion. Thank you.
Great. Thank you, Katie. I think we've got all of us back here now. So we've got a lot of good questions in the Q&A. Unfortunately, we probably won't be able to get to all of them, but I'm going to do my best here. I think what I want to do, again, is go back to Patrick for a minute to talk about, because you only sort of flash the slide for a minute, to talk about some of the strategies that have worked well. And for you, in terms of cost containment and particularly working with these kind of intermediaries, there have been a lot of questions that have come up in the chat about, in the success you've had around cost containment, how has that played out as far as the satisfaction of the members, quality outcomes, if you can speak to that, sort of member input. One of the things that's so hard for employers oftentimes in changing relationships with some of these vendors and with networks is the employee pushback. So in the areas where you've been successful, how has that kind of played out with the members? And have there been problems with not being able to access certain providers, et cetera, et cetera? So really broad question for you.
Well, I guess I'll start out by saying that we usually hear that over and over again, especially with respect to implementing reference-based pricing. There's two reasons for that. Number one, frankly, almost every hospital hates reference-based pricing. And there's a fundamental reason for that. Basically, reference-based pricing says we're going to set a baseline price, which is usually what Medicare would pay you for the same services at that facility. And then we offer a multiple of that. Typically, our plan is basically going to do 140% of Medicare. So you do a bundle of services. But hospitals have long been able to say, no, we'll set the price and then we'll negotiate a discount off of our price. Well, the reason we do not like that is the hospital can set the price wherever they want. And so 50% off this, we'll say a 50% discount off a high-priced hospital is a lot different net than 50% discount from a low-priced hospital. In other words, who's controlling the net price? Reference-based pricing says we're going to use a baseline that's commonly referable and available to see versus a discount off of a price that the hospital sets and is not always that clear to anyone. That's a power struggle, basically. And that is the reason hospitals will tell people, oh, this is terrible, it's unfair, and all of that, as you would expect. Now, the other argument is when they bill, sometimes they're going to bill a member, and the member's going to get a bill that's a lot more than they expected, even when you use reference-based pricing, or they might try to refuse admission. If you're going to do reference-based pricing, you're going to have to deal with all of that. And there are people that can help deal with that. You need to have robust legal support. You need to be able to reach out to those members and say, don't pay the bill just yet. We're talking to them, trying to work it out. We have had cases that have gone to litigation. We have sometimes settled for amounts more than our base 140, but maybe we'll settle and say, okay, we'll give you 200% of Medicare. That's still much less than we would have paid using a conventional PPO discount. So you do have to do more work to make reference-based pricing work. My argument for it is, even with all of that, our net savings, I don't like to call it savings. What I like to call it is cost avoidance. We are avoiding millions in costs that we would otherwise have to pay by using reference-based pricing. And that's net of all the additional expenses. So you will spend more administratively to have reference-based pricing. But the bottom line is we have literally saved millions of dollars over the year, even with all of that in consideration.
Okay, thank you for that. I'm going to go to some of these other questions here. One of the questions that came in early, and this would be a question for all of you, is what do you see as the largest conflicts in this whole distribution chain that we're talking about? What is the largest conflict of interest that skew against the customer particularly the patient or the employee, and sort of given the web and the map that Andrea showed us, there's so many pieces to this. Where does a purchaser really need to focus most? And I'd have a follow-up question to that, but let me throw that to you all. I don't know who wants to take that one first. Maybe Katie or Andrea.
Sure. I think maybe I'll report a little bit. Andrea mentioned a paper that we wrote together where we did a number of interviews. And I think one of the biggest conflicts of interest is the insurer often does the negotiation. The insurer TPA does negotiation with health plans as sort of one negotiation, or that's often done that way, both for fully insured and self-funded plans. But then there's all kinds of different amendments that are made there. And I think in some sense, for example, we heard that sometimes the health system would agree to remove the anti-tiering for the fully funded products as long as they could still keep them in the ones that were for the self-funded plans. That's just kind of one example. I think in many ways that's one of the bigger conflicts. Also, in terms of the way brokers, et cetera, are paid, if it's a percentage or a commission off of services. So often a broker might be paid both by the employee, but also when they choose a plan, that plan might give them compensation for choosing that plan. So the broker might have conflicts of interest. Maybe I'll let Andrea pick up on anything else.
This might feel a little indirect to the question about how does it impact the employee or the end consumer, but I didn't really explain it fully, but there's between a TPA and the repricers that I was talking about, and for out-of-network services, and many out-of-network services now are behavioral health, substance use disorder, and so they're high price, but there's high consumer need and high demand. And many of those providers are out of network, and an employee can experience a conflict here in the sense that these are not covered by the No Surprises Act provisions. And so patients are not held harmless. And what happens is that it sounds really good. The TPA is going to work with the repricer to reduce that out-of-network payment and hold that patient harmless from from a balanced bill. Unfortunately, that doesn't always happen. This patient sometimes has to pay upfront, and then whether or not they get reimbursed is to be determined. But the other conflict here is that in negotiating a lower amount, the TPA and the repricer share in what's called the savings. And so the higher that bill is to begin with, and then the negotiated amount, that's a bigger delta. And if they have a high percentage on a bigger delta, they're going to get, the employer is going to have to pay more fees for that service. And so it's, in some cases, that example is a very direct, it can have a direct impact on the employee and the consumer because they might have to have a balanced bill. But in other cases, it just exposes the how misaligned incentives, that shared savings fee. Yes, it sounds good that it's the employee is not, or excuse me, the employer is not paying the full out-of-network price, but of what? And the larger that delta is, the more the fee is.
Yeah, let me jump in and just add to what Andrea just mentioned. On my slide, that's one of the things we have done for quite a long time. We feel like, yeah, we should pay for savings that our TPA or somebody discovers save us money. But what we have done is said, we're going to put a cap on the total dollar amount of shared savings. So let's say the agreement is you get 25% of the savings, but we'll say up to X. And once you get up to that amount, we're not going to pay you 25% over this threshold. We're still paying them a lot. The argument is it doesn't take that much more work to achieve savings on $1 million bill than it does on a $100,000 bill. So it doesn't make sense to say you get 25% of the savings on the million as well as the 25% on the 100,000, because our argument is you didn't have to do that much more work to identify savings on the million compared to the 100,000. So the way we deal with it is we put a ceiling on the total savings that we'll pay them.
Great, thank you. Another question coming in through the Q&A is asking about the idea, and I think this goes for Katie, maybe start with Katie, but the idea of TPAs and PBMs and others acting with loyalty and care to the extent that that is required as a fiduciary. What does that look like in practice? What are the guidelines that they can follow, and how would that be enforced?
Yeah, I think the answer here is that it's not completely clear kind of nationwide. There've been lawsuits against employers. There's been employers suing their TPAs. There's even sort of an apparent circuit split about whether TPAs are fiduciaries and probably more precisely sort of in what cases are TPAs fiduciaries and when they're not. So I would say in some ways it is kind of a complex mess right now that I would highly recommend policymakers think about clarifying. And so that's one of the reasons I really pointed out the Indiana law, because there's a lot of disclosure here, and there's a lot of the TPAs are just not allowed to enter into contracts where they would have a conflict of interest. And I think California's law that's only about PBMs, but it restricts kind of the kinds of ways they can contract and prohibits kind of the exact spread pricing, a number of these arrangements where there are conflicts of interest. But this is a place where there's also lots of entities that could act, where the Department of Labor could just clarify what it means to have control over or discretionary control over plans. States could act here, but it really is somewhat unclear. And I think employers are really caught in the middle. They're both being sued and suing TPAs. It's really a complicated situation.
Anyone else have they want to add to that? There have been a couple questions or comments that have come in about sort of the interaction between public and private purchasers, various aspects of it. I'm just gonna read this one because it's an interesting question. I hope I get this acronym right. From SFGHP perspective, I'm assuming that's self-funded group health plan perspective. Is it helpful at all to have the ability to opt in to a state law regulating fully insured plans at their option? And the commenter is saying, we do that in Washington state with our state balanced billing law and are about to implement with our new PBM law. Would this give the self-funded group health plan the ability to benefit from state law without the state taking enforcement action with respect to the plan? What are your thoughts about that? I don't know who wants to take that.
I actually feel like I should take it, but I'm not all that familiar with the practice actually of opting in. Maybe it's a more recent activity. I think it sounds like a good idea for a self-funded employer to be able to opt into certain state-based protections, as were described. I think some self-funded employers and maybe their advisors would say that's a slippery slope, and you actually, I imagine there would be legal challenges related to it that, no, you don't get the protection of a state law because you're governed under ERISA. So I'm not familiar with how the opt-in function works in practice. I think it sounds like it could be a good option for self-funded group plans. Just I don't have experience with how they do that.
Yeah, if I could jump in for a second, I think this person is from Washington, and I think Washington is relatively unique in the opt-in for balance billing. Their law actually predates the No Surprises Act. The other laws that I talked about, sort of specifically in Indiana, in California, et cetera, don't try to regulate the plans. They actually regulate TPAs and PBMs operating in their states. So that kind of gets around this whole self-funded versus fully funded issue, or sorry, fully insured issue. There may be an issue if you're trying to demand what what self-insured plans would pay if you're actually trying to regulate what the plan is doing. I still think opting in should work, but there are ways around, in most cases, there are ways to regulate the entity doing the action rather than the plan itself.
Okay, thank you. And I see the questioner provided some additional information. Unfortunately, our audience can't see that, but we'll have to think about whether we want to try to do some follow-up answers to some of these questions. We only have a few minutes left, so I'm going to pivot a little bit to a kind of a more general question for all of you. Again, maybe start with Andrea on this one, because I noticed in your report on the out-of-network providers that you've mentioned that your team was unable to get any providers to talk to you as you did a series of expert interviews. You know, that resonates a little bit with my experience in running this Forefront series. The provider voice is one that we don't often have, and a lot of that may have to do with who we are as health affairs, and you know, whether we're doing a good job reaching out to providers. But it's hard to engage. It's hard to sit down and really engage with both sides of this conversation. So I want to, when it comes to cost containment, to really engage with both sides. So I want to ask you, as kind of closing thoughts here, what do you think really are the prospects for employers, and I use that term broadly, purchasers, unions, Taft-Hartleys, to find common ground with providers on these issues of cost containment, or on their use of these kind of third parties?
Yeah, you know, the out-of-network research that we did was revealing, in the sense that, you know, out-of-network providers did not want to talk about why they remain out of network. But there are lots of other explanations, or, you know, kind of side research or side information that lead us to realize that part of the reason providers stay out of network is that they don't want to deal with the insurer, or they don't want to deal with the TPA and the rules that go along with that. So if an employer, in that case, the employer is kind of stuck. But one way that employers and providers who might be out of network right now can maybe come to terms, and should come to terms, is a direct contract. Now, direct contracting comes with a lot of complexity as well, a lot of sophistication, challenging for even some of the largest employers to do. So I'm not saying that it's an easy lift, but it makes sense for those providers to want to see employees, and their employees, I should say. And I don't think hospitals or out-of-network providers want to balance bill and put members into collections and things like that. And certainly employers don't want their members to be balance billed either. So, you know, they have an aligned interest there. So I do think if the TPA or the insurer was not in the middle of that relationship, I imagine that employers and out-of-network providers could come to terms. And I would like to think that they could in a simpler way than it is right now.
Let me just add real quickly. I have frequent conversations with financial people at different hospitals where there's been a balance bill issue, maybe not even by the hospital, but they've got a contract collection agency. And I will say, hold off on the billing. Let me look at what you were paid. Give us some time to resolve the matter. And I would say, for the most part, a lot of them will agree to that. There are some that are going to be stubborn, and they're going to aggressively continue to balance bill despite our pleas. The exception, the concern I have, is the No Surprise Act is a good example. That was to deal with the classic problem of a lot of hospitals contract with an outside entity to staff the emergency room. And that is where a lot of the No Surprise Act was generated, because people were getting huge bills going to an in-network hospital, but they were being serviced by an out-of-network physician or PA or what have you. The problem with the No Surprises Act, I think it has effectively protected individual participants to some degree, but the assumption was the dispute resolution process would fairly arbitrate between plan sponsors and providers. In fact, 85% of the arbitrated decisions have been in favor of providers, not payers. And so a lot of us are skeptical that the arbitration process in the NSA has turned out to be fair. We feel it's kind of slanted to the provider side.
That's a whole, that's another webinar that we have had and probably will have again, but Katie, any last comments?
I would just say that, we're talking about engaging providers, and in many of the conversations that we have, I think that they really are trying to provide good healthcare at reasonable costs. It's just a matter of sort of misaligned financial incentives kind of all up and down the chain, and really trying to kind of align those is really important. Andrea mentioned some, maybe direct contracting. There's all kinds of tweaks around the edges, and we may want to think about sort of small tweaks and big system reform as well. So.
Okay, well, with that, we are at time. I wish we could go longer because there are a lot of great questions here. And as I said, I'll get together with the speakers and see whether there's any way to try to answer some of them. But I think this will be the first of many conversations on these topics. I know we are going to be doing something in the spring to dive deeper into these issues about provider prices and the way that employers and purchasers in general are dealing with them. So keep an eye out for that. But with that, I'm gonna do a little wrap up here. I want to thank everybody who joined us and attended today. Again, our discussion was brought to you by Arnold Ventures. We're very grateful for their support of this work. I want to mention a couple of upcoming events that will be just in the next month here. So on December 3rd, from 1 to 2 Eastern, we are hosting an exclusive event for our insider members. Where a team of our editors from the journal will be discussing some of our most memorable submissions and taking audience questions. So it's a great opportunity to see some of the folks behind the curtain that are responsible for the content getting into health affairs. And then on December 11th, from 1 to 2:30 Eastern, we're having a virtual event on private equity's impact on the practice of medicine, moderated by Ativ Mehrotra of Brown University. So you can find out more information about both of those events on our website, healthaffairs.org. And with that, again, I really want to thank our speakers. A lot of prep went into this. Thank our audience for being really engaged, had a lot of great questions. And thanks to our sponsor. And with that, we are adjourned.